to thank the Friends of Concordia for their support. It makes these programs possible. And I also want to thank Gene Scarlatta at Womrath Books, not only for selling the books after the program, but he's the one who made the connection to our author tonight, so I'm very grateful to him. Thanks, Gene. I'm delighted to welcome Dr. Joshua Kosowsky to Concordia. He's Vice Chairman and Clinical Director of Emergency Medicine at Brigham and Women's Hospital and Assistant Professor of Medicine at Harvard Medical School. He is the author of several scholarly articles, co-editor of Pocket Emergency Medicine, and serves on the editorial board of Annals of Emergency Medicine and the American Journal of Cardiology. Dr. Kosowsky leads a national course on emergency department design for healthcare and design professionals, sponsored jointly by the Harvard Medical School and the Harvard Graduate School of Design. And his pioneering work in redesigning the delivery of emergency medical services has been nationally recognized. It's particularly gratifying for us here at Concordia, where our nursing program is recognized for a unique course requirement, the spiritual and cultural dimension of nursing care delivery. This course explores faith and its role in guiding the nurse and healing the patient. It also requires students to focus deliberately on the whole person as central to their practice and ministry. In their book, When Doctors Don't Listen, How to Avoid Misdiagnosis and Unnecessary Tests, Dr. Wynn and Dr. Kosowsky also focus on treating the whole patient. Their book focuses on ascertaining and understanding each patient's story and how his or her story holds the key to an accurate diagnosis. Common sense, really, but as the book points out, so often doctors today approach the patient as if everyone was all alike, and rather than really listening to each patient's story. In a letter of advice to a young writer, Hemingway said, "When people talk, listen completely. Most people never listen." Certainly, listening carefully worked for Hemingway, and as Dr. Kosowsky's book points out, doctors can learn a lot through careful listening. But what I especially admired about the book is that it empowers the patient. In this new era of healthcare reform, it provides a far-reaching prescription for the way we approach and receive medical care, and reminds us, like every successful relationship, both doctor and patient must work together to make a successful connection and accurate diagnosis. Please join me in welcoming Dr. Kosowsky.
Thank you for that very gracious introduction, Ellen, and thank you again, Gene, for helping make this connection. It really is quite a pleasure and an honor to be here, to recognize some familiar faces and lots of unfamiliar faces. The opportunity to get up and speak in front of patients and healthcare professionals is one of the real joys that I've had over the past year or so since the book's come out. Actually, since the book came out back in January, I think my biggest fear was how I would be perceived by my colleagues. After all, when you write a book whose title is When Doctors Don't Listen and you're a doctor, you can lose a little sleep over that. Let me also, for those of you who may or may not know anything about the publishing world, let me tell you, give you in on a little secret. There are very few things that you hand over authority to the publisher of a book. One is the cover, and when you take a look at the cover outside, hopefully you'll appreciate some of the irony in the picture there. But the other thing that you give up control is the title. And so it was interesting, Ellen, you mentioned the idea of common sense. Our initial title, our working title for this book was actually called Common Sense Medicine. Of course, they thought that that wasn't going to sell any books. I mean, common sense, who wants to pay money for common sense? Everyone has common sense. So that's when they settled on this idea, When Doctors Don't Listen. And it was certainly a controversial title, but a controversial title that, in the end, I think really makes a point. When I think about the reception that we've actually had by doctors and other healthcare professionals, it actually has been really gratifying. And I don't know if there are professionals, doctors, or others in this group, but what I found is that more than almost anyone else, it's doctors, other healthcare professionals who really understand what we're talking about. Patients may have had their own experiences of themselves with family members of a doctor or another professional not listening to them, but doctors see this every single day, and whether it's them or colleagues that they witness, this idea that doctors aren't listening really rings true. And the fact that so many doctors have come up to me afterwards and said, you know what, what you're talking about really happens, tells me that we're really onto something. But maybe I shouldn't be surprised, because when Lena, my co-author, and I first set out to write this book, we actually thought about writing this for doctors. And much of the work that I do and continue to do, both at the medical school and at the hospital with residents, is about educating young doctors and doctors in training about how to be better listeners. And so it was only natural for me to continue to speak to that audience about the challenges that we all face with patients who may not always be the greatest storytellers, doctors who may not have all the time in the world to listen. And these are the things that we talk about all the time, and I thought this would be a great opportunity to talk to doctors. And yet, when we actually started putting things down on paper, what we realized was that the doctors already know this. In fact, this is stuff that we teach doctors in medical school from day one, and yet somehow that message is getting corrupted over time. Through their training, they're forgetting or not able to carry it forth on this idea of listening. And perhaps the only way we can get doctors grounded again is to go through them to patients and actually empower the patients to empower their doctors. And that's what we're going to talk about a little bit over the next 45 minutes or so. So let me go back to the beginning and start with where this idea germinated. So I didn't start out knowing I wanted to be a doctor. In fact, having grown up in a family where my father was a doctor and we had other doctors in the families, it seemed like being a doctor was sort of a very stable profession, but not something that I was really interested in. I had always imagined myself as being more of an innovator, more of a scientist, and the idea of sort of doing the same thing day after day after day as a doctor just never appealed to me. So throughout my undergraduate career, I saw friends of mine going off into medical school and figured, that may be fine for them, but I'm going to take a different path. Well, having graduated as a major in philosophy and mathematics, I found out I really didn't have that many options. Unless I wanted to be a philosopher or a mathematician, which I'll let you in on a secret, I wasn't good enough to be. So I looked around and saw, what were colleagues of mine doing, and I found that, the doctors, unlike what I thought when I saw doctors like my own doctor, and it seemed very routine, I found that the training was really, really intense, and these people were really learning how to interact with patients of all sorts in ways that were really, really meaningful to me. And so after spending some time figuring out what I wanted to do, I went back, did my pre-med work, and went to medical school. But I came back to it with this idea that I wasn't just going to be a scientist, I was going to try to listen to every patient and sort of made that my goal. Well, what I found early on in my career as a medical student, that was actually very easy. They gave us lots of time to do that, and they gave us courses on how to listen. In fact, one of the things I remember very, very clearly was shadowing a senior doctor who was so senior he was practically retired, and so retired that he pretty much had no other responsibilities other than to just listen to patients. And this was my idea of what it was like to be a doctor. I thought this was fantastic. You could just go in and spend an hour listening to what patients had to tell you and figure out what was going on. And it really made a lot of sense. I also realized that it was going to take a lot of practice, that patients weren't just going to walk in and tell you what they had. You had to really figure it out with them. Well, that was medical school, but when you start residency, which is the real intense training that you do as a junior doctor, you find out that all this emphasis on listening, as important as it may be, it sort of becomes less of a priority. And why is that? Well, you've got tests to track down, you've got orders to write, you've got notes to fill out, you've got paperwork to go through. The patient almost, believe it or not, almost becomes second priority to all this other work. What you tend to learn during residency, for the most part, is workarounds, as ways to take shortcuts so you don't have to spend as much time with patients, as scary as it sounds. You would say, well, they came in with chest pain, there's some kind of an algorithm that I can manage, that if I get X, Y, and Z, I'll get a chest x-ray, I'll get a cardiogram, I'll send these blood tests, I'll come back in 5 minutes, maybe ask a couple of pointed questions, and then put it all together into some sort of formula, and hopefully we'll have an answer. And hopefully more often than not we'll be right. Now, that would be bad enough if that was just sort of a workaround that people admitted was not the way to do it, but listen, that's the best we can do. What's happened, though, is that workaround has sort of become a science, and that science is, in large measure, what we call evidence-based medicine. I know this is controversial, but when it comes to making diagnoses, this idea that you can just take a symptom here, physical exam finding here, a lab test there, put them together into some kind of formula and come up with an answer. When you think about it, I'm looking at this audience, I know you think that's ridiculous, but there's actually journal article after journal article after journal article trying to prove that we can do this. And a whole cottage industry has been built around this, and careers have been developed around this idea that rather than talking to our patients, we can just pick and choose a few items, a few elements here, and develop a diagnosis based on that. Well, there's a couple of problems with it, other than the obvious, which is that how can a doctor possibly figure out what's wrong with me without talking to me? And I'm going to give you some examples of how we know that's not true. The first is that if you look at how these algorithms are developed, for the most part, they're done by research assistants who come in and actually ask these questions. That's how they do it in the scientific method. Well, the research assistants have absolutely no training. Generally, they may be medical students, they may be undergraduates, they generally have no training in actually how to listen. So how could you possibly expect the quality of those kinds of answers to give you anything close to a real diagnosis? But perhaps more importantly, they miss the point of what a diagnosis is. Diagnosis it's a word that we sort of take for granted in medicine. I think for some patients it sounds like a scary word. But what really is diagnosis? Is diagnosis an entity? Is it a thing? Is it a destination? Well, in some ways, if you think about it as the answer to a formula, you can be misled into thinking that it's a single thing. But I think what I've found in my training and in my practice is that diagnosis is not a destination, it's a journey. That may sound a little wishy-washy, but diagnosis really is a practice to get you towards better understanding of what's going on with the patient. Now, how can you possibly do that? Well, you start out with patient symptoms, and patient symptoms are always going to be different because every patient is different. And the story of a patient's symptoms is really what lies behind their syndrome. And a syndrome is the entire picture of all their symptoms together. And then that syndrome can then lead you towards what we call a differential diagnosis. Differential diagnosis is just the list of all the possible things that this could be. And that may range from the trivial all the way to the most serious. So take, for example, chest pain. A patient who has chest pain, first you want to find out something about the story that gives you a quality of the chest pain, and then based on that quality, you can develop a different type of syndrome. Is it a musculoskeletal syndrome? Is it a respiratory syndrome? Is it a gastrointestinal syndrome? And then you can break those down into different types of systems that would give you a sense of what exactly is going on. So once you've done that, you then have to decide, well, what particular diagnoses might that represent? So let's just take something trivial. Let's say we think it's a musculoskeletal syndrome causing chest pain. Well, you can get as specific as you want. What particular muscle is causing the pain? Or what bone is causing the pain? Or what cartilage is causing the pain? And why might that happen? Again, in order to start figuring that out, you're going to need some kind of a story. Like, did this patient pull a muscle? Is there something about that story that would sound like there might be a broken bone? These are the types of things that you have to go into the diagnostic process with some knowledge. That's what the doctor brings to the table. But ultimately, it's the patient's story that collaborates with that differential diagnosis to lead you on one pathway or another. Think about how different that is than just saying, chest pain, 45-year-old woman, left side of her chest, plug it into an algorithm and expect to get some kind of an answer. It's virtually impossible and almost nonsensical to think you can do that. So knowing that you need to understand the patient's story in order to get to a diagnosis and work with a patient to get to that diagnosis, how do you get a story from a patient? How do you actually get a bunch of symptoms from someone, particularly someone you may not have anything to do with? Now, in my field, in emergency medicine, I meet 20 or 25 patients newly every single shift. I just worked the other night, and the patients were coming in literally every 5 or 10 minutes, a new patient, a new face. I had to very quickly form some kind of connection with that patient and get a story from them. Well, how do I do that? Is it just asking a lot of questions to them? Unfortunately, that's how we're trained. We're trained to ask a lot of questions, and if you've been to the doctor, you know what that's like. You just get bombarded with questions. Now it's to the point where they'll actually hand you a sheet and say, here, fill out all these questions, because it's so many we can't even get to them. I think about that. But it's really not about questions. It's about trying to figure out a story. Let me give you an example. Let's say you caught up with an old friend of yours who you hadn't seen for a while, and you want to find out something about what's been going on with their life. Would you start out by just peppering them with 30 or 40 questions? Well, probably not, because you don't know if those are even the right questions to get to what might be going on with your friend. Instead, you're going to open up a dialogue, have a conversation, and you'll start to find out through natural conversation what's going on with your friend, and what might be important to them and what might be important to you that you can transmit to the patient, and you go back and forth. And that's really a much more effective way of getting a story. When you think about your own lives, storytelling is an art, and you get it not by delivering questions and trying to get the answers to them. I mean, imagine, so the ultimate storyteller, imagine someone delivering a joke that didn't have any of the build-up and just had, some facts and then a punchline. It wouldn't make any sense, and it would obviously miss the point. So there's an exercise that I do with my students now, and I call it No Questions Asked. So what does that mean? Well, we go into a patient's room, and I say to them, I'd like you to get a full history from this patient. You can have 15 or 20 minutes, and you're free to take the conversation anywhere you want. But at the end of the day, I want you to tell me what you think is going on. And they're like, great, we've done this 100 times, we can definitely do this. I said, just one thing though, you can't ask any questions. And they're like, well, then forget it, it can't be done. So I said, well, you know what, I'll modify that. You can actually ask a couple of questions. You can ask why, and you can ask any question about their non-medical situations. You can ask questions about what they do, their job, where they live, those kind of things, because otherwise I could imagine it would be awkward if you just walked in and didn't ask who you are, that kind of thing. So you can do that, and you can ask any why questions. So they they look at me sort of quizzically and say, well, I'm not sure we can do this, but you are our professor, so we'll give it a shot. They walk in, and I have to tell you, the stories that they come out with are unbelievable, because instead of hammering these patients with question after question after question, what they get is a story. And the story leads in the direction that inevitably leads to the diagnosis. Now, again, these are medical students, and they may not know that it leads to the diagnosis, but they tell a story to me that I can then work with them and say, you know what, this story really sounds like a GI syndrome. It sounds like it's probably coming from the esophagus. There are only a few things that would cause this kind of pain. It sounds like esophageal spasm. And they're like, wow, how did you figure that out? And well, you told me the story, and it's really their story. And that's when that happens, that sort of light bulb goes off in the student. And you go back to the patient, and they're like, that's unbelievable that you're able to figure that out. I've been in the hospital for 2 weeks getting tests, and no one's able to tell me. Well, it's not magic. It's just that it takes some practice to do that. Unfortunately, I think the way our modern medicine is being taught and being practiced, we're not allowing doctors to get that practice, because you can't just walk in off the street and start doing that. You need months and months and years of practice to get good at it. I mean, I consider myself fairly good at it now, but 10 years ago, I had graduated a residency, medical school. I'd been in practice for 3 years, and I would say I was okay at it, but not very good. Now I'm somewhat better, and I'm hoping to get better still. And although it's kind of cliche, I think that is ultimately why they call it practicing medicine, because you are supposed to be getting better at it. If the idea is that there's some algorithm out there where I can just plug in some values off a computer, I hate to say this, but doctors would be out of business pretty quickly if that's all it was about. And it really would sort of lose the mystique if not anything else. When I'm talking to skeptical doctors, I say, if you really believe what you do about these algorithms, that you can just, ask 1 or 2 questions and put it together and get an answer, you're going to put yourself out of business, because there are computers right now that are trying to do that, and some of them are actually pretty good. You've probably heard about IBM Watson, the computer that beat the Jeopardy champion. Well, they've actually tried to apply that to diagnosis in medicine, and for some applications it actually can work if you plug in the right information for some obscure diagnoses. But imagine Watson trying to figure out the meaning of a patient who may not be all that forthcoming, who may not be wanting to tell all the details of a very personal story, who may be either minimizing some parts of their history because they're embarrassing, or maybe overplaying some parts of their history because for dramatic effect or something like that. These things happen. Who better than a doctor who does this all the time than to figure those things out? And that really does take practice. We talk in the book about what a lot of young doctors call the poor historian. The poor historian means the sort of blaming the patient for not telling a good story. And at least once a shift when I'm working in the emergency department, one of the junior doctors will present a patient to me, and the story's kind of all over the place. And I'll say, well, that story really doesn't make any sense, does it? And they're like, well, the patient's a poor historian. And I say, well, maybe, or maybe it's a poor history taker. And more often than not, it's not the patient's fault. You really can't blame the patient. Sometimes the patient is through no fault of their own. They may be suffering from dementia, they may be delirious, they may be intoxicated, they may be stressed out, they may be depressed. There may be lots of reasons why they can't tell a coherent story, but that's our job, is to figure that out. But now imagine Watson trying to figure out the story from someone who's delirious or demented or intoxicated or depressed. Almost impossible to conceive of. You know, there's this idea that medicine advances as science evolves, and there's definitely truth to that. I was at a conference this morning where we're talking about a revolutionary way of doing medical advancement. So rather than relying on randomized controlled trials where you enroll tens of thousands of patients and subject them to rigorous testing with particular treatments or other treatments, and then comparing them and looking for statistical significance in the differences, looking at how often does that really change our practice. And truth be told, when you actually take skilled doctors, and this was actually a study done at Children's Hospital in Boston, they followed these skilled doctors around and cataloged all the decisions that they made over the course of a day. Do you know what % of their decisions? These are really skilled doctors all of you would want to go to or send your children to. Do you know what % of those decisions were based on sort of the high quality evidence-based medicine? About 3%. The other 97% were based on their clinical experience, their gestalt, their sense of what the patient will be best for the patient, maybe some general knowledge of science, but not really these studies. In fact, it would be almost impossible to try to design studies that would take into account the differences among our patients. When we talk about these large randomized controlled trials, you have to remember these are giving you a good indication of what happens to the average patient. So if I said, for example, let's say I was able to do a study that said, on average, young women who have chest pain right here on the left side that hurts when you press it, on average, those patients do not have heart disease, for example. Right? And let's say I was right 95% of the time. That would be a spectacular advance if I could ever get to that point. And that would be true for 95% of the patients, except for those 5 patients where I was absolutely wrong. And what about them? And take another example, like take even something as basic as treating patients for high blood pressure, which we all agree, a tremendous advance. If you took all the patients who are getting medicated for high blood pressure to prevent stroke, let's say you took 100 patients, 100 people in this room, all of whom are getting blood pressure medicine. Well, a certain number of those patients, you're going to prevent them from having a stroke. Any idea what that number is going to be? Somewhere around 5 or 6, right? There's going to be 90 patients who would never have had a stroke anyway. And there's going to be 3 patients who are going to have a stroke regardless. So the impact that we have with our medicine, you know, it's to have a little bit of humility here. It's a very small impact. But those other 90%, that's the large majority of our patients. So we have to think, you know, who are these people? You know, what is actually right for them? The fact that on average most patients get better with a certain treatment doesn't mean that this individual patient might get worse, this other patient might get dramatically better, and this other patient, it might just be, you know, an unnecessary cost. It's bad enough on treatment, where at least with treatment we can take groups of patients and randomize them into treatment groups. When it comes to diagnosis, it's even more challenging to try to figure out one diagnostic strategy that would work for everyone. As I said, the diagnosis is based on a story, not on a set of facts. And so just based on that, it's almost impossible to imagine a single diagnostic strategy for all patients. But even beyond that, the range of possible diagnoses that patients have and the interactions among those diagnoses make it inconceivable that there'd be one way to approach all these patients. Let me give you an example. Let's say a young person with pneumonia versus an old person with pneumonia. Right? A person who is completely healthy versus someone who may have diabetes and hypertension and cardiac disease. The way that they present is going to be completely different. And so if there's one diagnostic algorithm that fits a young person, it's very likely it's not going to fit the older person. Well, then someone was going to say, well, why don't you just add age into your algorithm? Put that in too. Well, okay, some of the algorithms do that. They say, oh, age over 70, we're going to go down this path. Age less than 70, we're going to go down that path. And then, like, my response to that is, oh, well, what happens if you're 69? Does something magical happen when you turn 70? Is that really what's going on here? So many of our algorithms, because once you have to put them into a computer or put them onto a spreadsheet, you have to decide, well, what are we going to do with those things? And a lot of these things are discrete. So the algorithm may ask you, does the patient have chest pain or do they have abdominal pain? Well, what if the pain is right over here? What is that? Is that chest? Is that abdominal, right? What if it's both? What if it's kind of comes and goes or the patient can't really describe, right? That's much more likely the case in a real situation than someone who comes in specifically and says, this is what I have. I like to sort of say half jokingly with colleagues of mine who don't work in the emergency department that when a patient rolls in through our doors, they very rarely have a sign across their forehead saying, here's my diagnosis, right? That's very unusual. Now that may be different if you work as, say, an endocrinologist and you're seeing only patients with diabetes. There may be some room for taking patients with a very specific type of diagnosis and then deciding, again, based on well-designed clinical trials, what kind of treatment you want to offer them. But when a patient just walks in with an undifferentiated complaint, abdominal pain or chest pain is one thing. What about dizziness? What does dizziness mean? All right, how can you even describe what dizziness means and what dizziness means to one person versus a second person, not to mention what it means in different cultures? I have colleagues who, when they see a patient who has dizziness, they run the other way because there's no good algorithm to figure out what it is. And when I see a patient who has dizziness, I'm like, this is going to be fantastic because the only way to figure this out is to ask the patient to tell their story. Because there's nothing that I can measure around dizziness. I can't put a quantity around dizziness, so I'm going to have to involve myself with that patient. So again, these are all the types of things that for years I've been working with my students, with my residents to sort of get them to understand that this is what it is to be a doctor. And again, with limited success, because although it's sort of taken up at the medical student level, once people become residents and the pressures and the time pressures, it's much, much harder to carry out. Because you really have to be committed to this way of thinking because you have to do it for the long haul. In the short run, it definitely seems easier to take some kind of a shortcut and figure out what this algorithm might tell me. So, in it for the long haul thinking, this is going to be a lifetime battle. I'll just have to keep training all these doctors and maybe eventually we'll get some critical mass around it. It was really when Lena Wynn, my co-author, when she walked into my office as an intern, a sort of first-year resident, and we started talking about this, that we realized that there may be some other way to get to the same point, and that is to actually look at this through the lens of the patient. And that at first seemed like that may not be the best way to go, because after all, why would we want to sort of spill the beans and let patients know how terrible doctors really are? I mean, it doesn't seem like a really good thing to do. Well, we started sort of playing around with this idea that maybe what we really wanted to do is write something for patients, or maybe patients and doctors. And we sort of drafted an outline of what something might look like if we were writing this from the perspective of the patient. And we certainly were not at a loss for patient stories. There were lots of patient stories that we could call upon. And so we started jotting down some of these stories and really telling them not from the perspective of the doctor, but from the perspective of the patient, from the patient who really had no medical background but knew what it felt like to not be listened to. And it looked like this was going to take shape and, maybe we could turn this into a book. And when we met with a literary agent, she was very clear that, you guys got to decide. Are you going to write for doctors or are you going to write for patients? Because you really, you can't really write for both. They're a very different group. And we had to sort of do some soul searching to figure out, who really was our audience and did it really make sense to go to patients if the issue was the doctors. And it really took months of sort of mulling this over and talking with our agent, with colleagues, with friends, before we came around to this idea that it wasn't just a book for patients and exclusive, and sort of leaving out the doctors, say, listen, the doctors they're incorrigible, we'll write for the patients and hopefully they'll figure something else. At least they'll know why doctors are as bad as they are, if nothing else. And to come around and say, no, this is really not about that. What we really want to do is use the patients to empower their doctors. And this is like, well, how could you possibly do that? It's not really a power, people talk about the power imbalance there. One of the reasons why it's so challenging for patients is because, and this is true when I'm a patient, when you walk in and you're playing the role of the patient, it's very difficult to speak up and to say anything, let alone to change the way the doctor's practicing. And yet we thought that this was really an opportunity. And we had actually seen it in our own practice, examples of where this had actually worked. The rare patient who really was forceful and assertive, but not in an aggressive way, but in a way that really got you to take take a step back and say, I see where you're coming from. Let me recalibrate where I'm going with this diagnosis. And so we sort of latched onto this idea that even the most incorrigible doctor, at some point, when they went into medicine or were they in medical school, they heard something about listening to patients. They understand at some level that this could be important. They may just need to be reminded or coached on how to do it a little bit better. And maybe rather than me sort of haranguing them from, the position of assistant professor at a medical school, maybe what they really need to hear is from their patients themselves. And so that was the spirit that with which we wrote the book. So here's how it works. I walk into the doctor's office as a patient. I've got a story to tell. Well, before I can even get into the office, I have to realize that I'm going to be on a very, very short lease, because that doctor's only going to have a little bit of time. And so my story really has to be top-notch if I expect my doctor to listen to it. So I've got to do everything I possibly can to get that doctor's attention and to keep that doctor's attention. And I have to realize that there's a really good chance that within 18 seconds of me opening my mouth, that doctor's going to start interrupting me with questions, because that's what we know they do. That's been studied. So I've got to really be on my game. I've got to have my beginning, middle, and end of my story down pat. I've got to know all my facts and understand where I'm going with this. We sort of make the analogy to practicing for giving any kind of a speech, right? If you're going to go to your boss to to negotiate a raise, for example, and you know that your boss only has 15 minutes and he's a pretty serious guy and doesn't suffer fools, you better have your pitch lined up pretty well. Because if you go in there and start just shooting the breeze, or you let him take the conversation in some other direction, it's going to be, this looks like our time is up, and you wouldn't have gotten to your point. So what do we say? We say we need to practice. You need to practice this and practice this and practice this. And if you wait till the actual time where you need a doctor in an emergency, well, it may be too late. So we go through the book and give examples of how you would actually practice, whether telling stories about your medical conditions, whether telling stories in general. Not all of us are great storytellers, myself included. You've probably noticed not all of my stories are great stories. But there's something about telling a story again and again that makes you get better at it. A good story, like I said, has to have a beginning, a middle, and an end. It has to have some kind of a trajectory to it. A great story not only captures the attention of the audience, but it actually makes the audience, listen for that punchline. And the punchline in a story about illness is the diagnosis. So you may not know the punchline if I'm the patient, but the doctor would know the punchline. And that's sort of an analogy we use in the book. But in order to do that, you really have to practice. So walk into the office already prepared to do that. And we give in the books what we call the 8 pillars to better diagnosis. The first pillar is know how to tell a good story. Well, it doesn't stop there, because like I said, the doctor's going to interrupt you with all kinds of questions, some of which may seem relevant and some may be irrelevant. And your job, because the doctor may not understand why they're asking those questions, believe it or not, they got so used to just sort of going through the litany that they're just going to do it because it's what they do. What you need to do is to refocus the doctor on, why are we asking these questions? And not in a mean way, but why would it really matter if the answer to this question was one thing or the other? So let me give you an example of what I mean. Patients like we're talking about with chest pain. Chest pain is a very common condition that patients come to an emergency department or come to doctors in general for. And one of the things that doctors worry about, at least a little bit, are beyond things like a heart attack, would be a diagnosis that we call aortic dissection, which is the rupture or tearing of one of the major vessels coming from your heart. Obviously, the reason why we worry about this is because it doesn't sound very good. In fact, it could be fatal if it's not recognized early on. And one of the signs of aortic dissection may be a certain kind of pain in your back. And so one of the things that a doctor is very likely to ask you if you go to an emergency room and talk about and say anything about chest pain is they're going to ask you about pain in your back. Now, the way they usually ask that is, are you having any back pain? The problem with that is that back pain is actually incredibly common, right? It's like one of the most common diagnoses, and in fact, but I think more people actually miss work because of back pain than illness anything else. So if the patient isn't understanding why the doctor is asking about back pain and what kind of back pain they're asking about and why it might be relevant, the quality of that answer is going to be very poor, right? Because if a third of the patients say, yeah, I've got back pain, and the doctor's now, oh my God, back pain, chest pain, maybe it's this horrible thing. So, and we see this happen, and then they start going down that whole pathway, and maybe we need to get a CAT scan to make sure it's not this and that. And in reality, the patient's just trying their best to be honest. But they didn't really know why the doctor was asking that question. Now, if instead the doctor explained what I just did to you about this certain kind of back pain and what it feels like, and patients who are having the rupture of their vessel and coming from their heart, and explain that to the patient would be like, well, yeah, I mean, I hear what you're saying, but the back pain I have is nothing like that. This is the back pain I have all the time because, I sit in a car for 2 hours commute every day. And they're like, great, okay, so now I understand why you're doing this. But again, because we train people to sort of ask the questions, doctors often don't think why they're even asking that. So one of the things that patients can do is to ask the doctor, why are we asking that question? Why is it relevant? And sometimes it may not be relevant, sometimes it's very relevant. So that's one of the things, one of the strategies that you can do as a patient to sort of train your doctor, making your doctor better for you and for the next patient that doctor sees. You've gone through, assuming you've been able to get through your story, and you've been able to have an interactive discussion with your doctor, that's not just a bunch of yes/no questions. The next step is really about taking that story, which will portray some kind of a syndrome. Maybe it's a gastrointestinal syndrome or musculoskeletal syndrome, or maybe it's still a little bit unclear about what that is, and then deciding what the next steps are. And this is sort of the next pitfall, again, where doctors and patients, if they're not on the same page, you can really end up going down the wrong tree. And this is where we talk about how to avoid unnecessary tests and misdiagnoses. Because when the doctor's thinking algorithmically, they say, well, obviously we don't have enough pieces of information. I've got answers to 3 or 4 questions, but I need some more data. And that data may take the form of a laboratory test, an X-ray, some kind of a stress test or something like that that's going to help plug in those pieces of information. But again, if the doctor is thinking algorithmically about just getting data points and the patient isn't understanding where those data points are coming in, the patient really can't be as helpful as they possibly can. So I've absolutely had the situation where I'm thinking along one direction, and I'm thinking, I'm really worried about the possibility of, let's say, a skull fracture. So I think I should probably order like a CAT scan of the head and see if the skull's fractured. But when I raise that question, if I just ordered it without involving the patient would go off and get the CAT scan and it wouldn't show anything, and we wouldn't be any wiser. And maybe this isn't the greatest example, but if I had said to the patient, hey, this is what I'm worried about. I think I might have a skull fracture, and that's why I'm ordering the CAT scan. They might say, wait a minute, but doctor, I never hit my head anywhere. I don't know, maybe you misunderstood the story, but when I fell down, I'm 100% sure that my head never struck the pavement. So are you sure you want to get that test? So again, when you're thinking about the next step beyond the history and the physical exam, going up to starting to order tests, not only do you want to make sure as a patient that you understand why the doctor's ordering it so you can help order the right test or avoid ordering the wrong tests, but most tests carry some risk to them. So for example, you may not think of it this way, but even a CAT scan, there's a little bit of radiation, and every bit of radiation builds up and contributes to the likelihood of getting cancer or who knows what. So why would you order a CAT scan if you didn't need one? There's also costs obviously associated with tests, and more individual patients are responsible for a portion, if not a large proportion of those costs. So is that something that patients should know? But I think actually one of the biggest risks of doing any test, and this is a risk that we often don't discuss with patients, is what I call the risk of the false positive. If you do enough tests, believe me, you will start finding things. And you've probably all been there, right? We have something called statistical significance, which means that if you run a test and there's a greater than 95% chance that the result is not due to chance, we're going to call that significant. What that means is that 5% of all of our tests may just be abnormal because of random variation. So if I order 20 tests on a patient, just by sheer randomness, one of those tests is probably going to be outside what we call the range of normal. Think about how many tests are in a typical blood panel, right? You think about all the possible things you could find on a CAT scan. There's more than 20 of them. So if you order enough tests, you're going to start to find things. Now again, if the doctor knows what they're looking for and the patient is part of that decision, then they can interpret those things and say, well, what we were really looking for was this abnormality. The fact that this other thing showed up, that's incidental. We're not going to worry about it. But if you don't really know what you're looking for, you're just sort of casting a wide net, hoping that some information can be plugged into an algorithm, you're going to start plugging really bad information into this algorithm and come out with results that make absolutely no sense. And we give lots of stories in the book where patients start out down one path and The doctor decides to order a test, hoping that there's going to be more information. It shows some other information which has nothing to do with why they were there in the first place, and now they've, down the garden path to more and more tests, more and more expenses, sometimes even procedures, biopsies of things that never really even had anything to do with why the patient was there in the first place. So you can see that this becomes a real risk, not just in terms of sort of the cost and the lost opportunity to make the right diagnosis, but real, risk to life and limb when you start adding more and more risk to procedures and tests. And so that becomes a real issue. And then, I would say our overarching theme is that the doctor needs to know that you're the kind of patient that is willing to partner with the doctor. And there's a little bit of a fine line there, because as important as the patient empowerment movement has been in getting patients and doctors to talk to each other, many doctors still feel somewhat intimidated and a bit defensive about a patient who comes in and says, "This is what I want." And our book is certainly not about walking into your doctor and saying, "I just went online and I read all about it and I want an MRI, I want a neurologist, I want that." Then you're not listening any more than the doctor who's not listening when they come up with a list of things that they want you to do. So it really has to be a dialogue. And navigating exactly how to do that, well, that's the skill that patients bring to the table. And everyone does it, we all negotiate in our lives, whether it's with our family, with our colleagues. So in some sense, it really is a negotiation, but it's a negotiation where you both have the same goal in mind, and that's your health. So I want to close with one item here, and that is this idea that patients and doctors ultimately are in it for the long run. Even doctors like myself, where I may only interact with a patient for 15 minutes while they're in the emergency department, we really are about more than just that one interaction. It's about how do we make our patients healthier for the long run, and patients thinking, how do I make my doctor a better doctor for the long run? And this is something where we all have lots of hope that healthcare reform will bring us to a better place, that medical education reform will bring us to a better place, but this is something that we can all do at the ground floor. Each of us, when we go to our doctor, and every healthcare provider, when they see their next patient, can be engaged in making ourselves better patients and our doctors better doctors. So I'm going to stop there. I haven't looked at the watch, so I hope we still have some time for some questions.
Thank you for the presentation. I have two quick questions. There's a story that you have to develop for a doctor that you have been going to for years. So there's a familiarity and there's a history. What about the pitch or the story that you have to tell when you call in for the first time and you have to talk to either the receptionist in a big hospital, and they're asking you not why you want the doctor's appointment, but what's your insurance coverage, and all the other things that are really inconsequential to the story. And sometimes there's a risk that screener will screen you out and put you on a waiting list for 2 months from now, when you're really developing some kind of potent illness that could be threatening. So do you have in your book how to present a story to the receptionist or the person that will be representing the doctor for that first appointment?
So, that's a real legitimate concern. I could actually imagine coming up with another book called When Receptionists Don't Listen. But when we actually talk about it in the book, there is this idea that if you can't get past sort of the gatekeeper, whoever it is, whether it's a receptionist or a triage nurse, if you can't even get in to see the doctor, that's a big problem. And we talk about a story about someone who was waiting in the waiting room for such a long time and couldn't get in to see the doctor. They actually induced vomiting, so at least it looked like they were serious enough to get seen for whatever it was that they were there for. Clearly, we don't recommend that. I think that's a real tough challenge. I think sort of the work of this book is predicated on the idea that there is a doctor-patient relationship to begin with, even however brief and however superficial it may start out as. But I will tell you that even as an emergency physician, where we don't necessarily know anything about our patients walking in, I try to find out something about my patient, something about them or their family or their background, before just sort of jumping right into the history of their illness. And it's not a bad idea for patients to do the same thing, is to humanize themselves before they start jumping into the details of their headache or their nausea or whatever the case may be. One of the things that we do, and again, this is, we do this to ourselves, is we dehumanize our patients before we even see them as doctors. So I know doctors who say, I don't want to see the patient until they're, behind a curtain in a gown. Well, already they're a patient. I'm exactly the opposite. I want to see my patient walk in street clothes so I see what they're like as a person. And then if I need to examine them, I can always walk out and have them get into a gown. But there's a huge difference between talking to a patient as a person and talking to them as a patient. And I think talking to them as a person is the first step.
Your idea to get to know your patient is admirable, and that's something I think everybody would want to have, that kind of relationship. But with the insurance demands, many doctors have a caseload, like you said yourself, 30 cases a day, 30 to 50 sometimes. The time doesn't allow to have more than 15 minutes with that patient and really get to have that history. It takes a lot more time to discuss that. Myself with a doctor, I feel sometimes rushed because I want to tell my story, but they don't have the time to hear my story. And if they do, then, they're there till, ridiculous amounts of time, and it affects the insurance and the reimbursement and the whole pocketbook part. How do you combat that?
So that's the most common question that I get asked. And usually the first question is, how do you have time? So we make the case pretty forcefully that if you do this, first of all, it takes practice, but if you do it right, it actually saves you time, because you can really focus on the things that are important and not focus on following up on tests that are irrelevant or asking questions that have no bearing on the situation. That this doesn't mean that there aren't real challenges. And that's, when I joked about the fact that they hand you the sheet and you have to fill out all those items, there are some, whether it's regulatory or billing or coding requirements that you can't get past. And there are ways around that. Fortunately with technology, some of these things you can actually even do before you get to the doctor. You can go online and fill out some information that's all sort of privileged and protected. But when it comes to that very crucial time where you're actually spending with the doctor talking about something relevant, as a patient, again, you have to practice to get that story as concise as you possibly can. It doesn't have to be 10 or 15 minutes. It can be 2 or 3 minutes. And you have to be committed to following through with that doctor and making sure, like, hey, if we didn't get through it in the first 15 minutes and your visit is over, well, we're going to come back and make another appointment. Don't give up on it, because in the end, if you just sort of submit to the, here's the routine, we're going to do a bunch of questions and do a bunch of tests, in the end, you'll end up going back 5, 6, 7 times to see that doctor and still not have any answers. So in the long run, I think we've been able to convince doctors that if you do it well, it takes practice, if you do it well, you'll actually save time. I use myself as an example, not to brag, but we've got lots of variation in practice in the emergency department. We've got people who are faster and slower. In general, we're all pretty quick about what we do, or else we wouldn't be in the business we're in. But I spend more time talking to my patients than most of my colleagues, and yet the length of stay that my patients are in the emergency department is by far the shortest. So why is that? Because I spend a little more time up front listening to them, and a lot less time ordering tests, following up on tests that aren't necessary, going back and giving the results of tests and findings that aren't relevant, right? So I end up saving time, but I invest some time up front. I think that's the argument that we try to make with doctors. As a patient, your job is to make that time that you have as efficient as possible with the doctor.
Thank you. My question is about the best way for patients to advocate for themselves. So what you're saying is terrific, and I can see how well it would work, but it is the mindset changing of just walking in and being a patient and waiting for something to happen, and walking in and saying, I'm here, presenting yourself as quickly and as effectively as possible. But how do you have any strategies for changing the mindset of a patient who walks in not ready to necessarily practice at advocating for themselves?
So that's a great question, and that's probably the hardest thing that we're asking patients to do. I mean, obviously practicing your story, being concise, being willing to work with your doctor, those are all the things that we talk about, but I think the hardest thing is being able to change a doctor's mindset. And the reason why that's so hard is because, like I said, many doctors are very defensive. And if you walk in and say, my goal is to advocate for myself, you got to turn a lot of doctors off, for better or for worse. They're going to put up their guard, and it's one of those kind of patients. And if anything, they're going to be even less likely to listen and just order a bunch of tests, so that I don't have to talk to you. So it's really important that we get this right. I think you almost have to play amateur psychiatrist with your patient, with your doctor. right? You have to understand what's in it for the doctor. What's really going to make the doctor feel good at the end of the day? Well, again, I have an innate belief that doctors at the end of the day are in it for the right reasons. And I think 90% of the time, maybe more, that's actually true. So yeah, there may be some quack out there, or some doctor who really is just about making money or, you know, status or something else. But most doctors really, the satisfaction they get is making patients feel better about solving problems, getting to a diagnosis. So you have to appeal to that side of the doctor. And the way to do that is, you know, sort of the same way you would appeal to anyone else's better instincts. You want to sort of let them know that you want to partner, you want to make them a better doctor. You want to help them solve problems that they are capable of solving that you can only solve together. You want to let them really achieve the ultimate in being a doctor, and you use you as their patient. This is, you know, how do you actually say that? You don't go in and say those words, but you have to convey that in a way that makes the doctor feel comfortable with you. And that may be easier if you've known the doctor for a long time, but you also gonna have to figure out ways to do that even with doctors who are brand new. Again, at the end of the day, I think doctors are receptive to that, but it's about appealing to their better instincts.
And if I can just quickly follow up, what do your colleagues think about your book? How did they react to it?
Yeah, so you know, I guess that's sort of the teaser I led off with, and the answer is that it's actually been remarkably well received. So number one, I still have my job, so that's good. Number two, most of my colleague doctors still talk to me. But more importantly, when I go to speak with audiences like this, there often are, you know, a number of doctors in the audience, or doctors who have, you know, read the book and email me or go online and say something, and it's almost always positive. In fact, it's the ones that the doctors who have spoken out in a way that's negative. If it has, it's really just been about practical concerns. It's the concern that we've raised. Like, we really want to do it, but how do we do it? But it's never about, guys, you know, I can't believe you're spilling the beans about how we really act. They know that this is true, and they want to do their best to make this better as well. So overall, it's been very gratifying to know that we're not the only ones who are talking about this, but that it really is a concern of lots of doctors.
I want to thank you very much for doing this. I teach courses on communication, and no matter how many years I've been doing this, more years than I'd like to count, the one form of communication that most participants are not aware of is listening. So that's the one skill that I teach people, to just ask somebody to please listen. So that's the first thing. So I congratulate you on bringing that to the awareness of most people. The other thing, too, is I find that for me personally, the thing that worked best with a doctor is developing a relationship with that doctor. If I don't feel a good chemistry with that doctor, I'd rather not go to them, because I want to know that they would listen to me. The best doctor I ever had sat there and said to me, "Tell me what you think is wrong." And finally, when you say that you can put a doctor on defensive, I had a son that was sick and had surgery twice, emergency surgery, and I finally had to say to the surgeon, "No disrespect to you, but I'd like to know what the problem is. Can we research it?" And his back was up for a few minutes until he realized that I don't want to be back in the operating room again. So that I think it's important to approach anyone with confidence that you know what you think is best, but also not to put them on the defensive and say, "I want to know, I'm uncomfortable, I need." So I think that when you're saying to communicate to somebody, to not put them on the defensive and never say you, always say I.
Any other questions?
So I would just agree. I mean, I think all those are really, really important points, many of which we talk about in the book. And I think this idea that you need to develop a relationship with a doctor and feel comfortable with them. You know, these are, again, things that we teach doctors how to do. We teach them how to sit down at the bedside, how to appropriate distance with patients, eye contact, reassuring gestures, all that stuff. Again, doctors learn how to do it, and then they sort of forget. And this is about re-educating doctors about how to do that.
Any more? I want to thank you. It was wonderful.